Okay, we're back. We're about to do the third lecture on mobility. This lecture will actually begin with sprains and strains and a continuation of traumatic injuries, and then it'll move into amputations. Shouldn't be too long a lecture, but I'm going to go ahead and share the screen and go to my PowerPoint. All right, we're starting with sprains and strains, which are traumatic injuries, not as bad as a fracture, but can still take several weeks to heal. It can be really frustrating because you don't have to have a cast and you don't have to have surgery. You just have to wait it out. A sprain is technically a ligament that is torn or stretched. Ligaments, as you know, connect bone to bone, whereas tendons connect muscle to bone. So a strain is when the muscular tendinous unit is actually stretched or torn. So there's a difference, one ligament, one tendon. But the treatment initially for both is the same. We start treating with RICE, rest, ice, compression, and elevation. So the first thing is get the person off that extremity. Don't let them keep walking. Don't let them go about the process of going about their business. We need them to stop working that particular area so that the tendons and ligaments aren't further damaged, that the bleeding doesn't continue. We'll apply an ice pack. Now that doesn't mean continuous. Anytime we apply ice or heat to an injury, you always inspect the skin before you start, document carefully what the skin assessment is like, apply the ice or the heat for 20 minutes, and then document the skin again afterwards if you're doing it to another person. If you're doing it to yourself, you're obviously not going to have to document your own skin. But that's the treatment with ice, or you don't use heat on these, you use ice on these initially. Heat might come later, but initially, remember, ice is meant to decrease future swelling and prevent the massive inflammatory process that causes the swelling and encourages the further bleeding. The next thing we're going to do is compression. Typically, that involves an ACE wrap, a compression elastic bandage that you will wrap from distal to proximal. So you go from the bottom of the foot or the ankle up towards your knee in the same direction that the venous return is moving to try and promote blood flow up the leg or up the arm. And then we'll elevate it. We'll keep that extremity elevated as often during the day as we can. We want that elevation to continue to decrease the bleeding and the swelling. So RICE, rest, ice, compression, and elevation is pretty much the standard of care for a sprain or a strain, at least initially. So there's RICE again. And then after we've elevated and got the swelling down, and it's a little bit more manageable, then we'll begin the process of range of motion and remobilization. You want to follow the provider's orders for that because they probably are going to want you to rest it for a week or two and then begin that process. But that's just something to think about. There are lots of sprain and strain injuries and repetitive use injuries. It doesn't always have to be tripping over a curbside or into a pothole and causing a strain or a sprain of your ankle or your wrist when you fell. Even very common in our country is rotator cuff injuries and anterior cruciate ligament injuries. A rotator cuff tendon attaches the muscle to the bone in the shoulder, and those tendon injuries are pretty common. We can repair them with surgery if they won't repair on their own. Tendons and ligaments in our joints like this can take weeks and weeks and weeks to heal. So it can be pretty frustrating. A lot of times we go ahead and do surgery and just go ahead and sew them back up and treat that through a surgical intervention because it can be a quicker healing time sometimes. An anterior cruciate ligament, ligaments connect bone to bone. So this is an anterior ligament in your knee that connects the bones of your leg together. And that ligament can get torn. Carpal tunnel, however, is a repetitive use injury. It actually happens because of a narrowed tunnel that the nerve is traveling through the radial opening from your arm into your hand. So carpal tunnel is literally compression of the nerve as it passes along the tunnel or the channel from the radial artery, and the radial nerve travels through a channel from the arm into the hand. If the nerve gets compressed, the client will complain of numbness and tingling and pain in their hand. Typically the thumb, the pointer finger, and the middle finger will all be numb and tingly. Quite often they'll have thickened and drier skin because not only is the nerve impacted, but the vasculature can be impacted through that tunnel as well. So that would cause the dry and thickened skin. It's a little bit poor perfusion. It's kind of a long-term change from minor reduction in perfusion. What we'll do is a Phelan sign, We'll have the patient bend their hands like this. And if it causes pain, the typical pain we associate with carpal tunnel, we close off the tunnel when we bend our wrists and past 90 degrees like this. If we want a test done through a muscle physiology lab, they can do a nerve conduction velocity test that will also determine if it's carpal tunnel or not. High-risk activities that can make this happen to more people: smoking, it's tied to everything. Wait till we get to the cancer unit next. Smoking, obesity, being overweight, excessive caffeine use, and repetitive movements. So dental hygienists, people that write with hands, computer keyboard operators are constantly flexing their wrists. So people who have repetitive movements constantly in their wrists. The next mobility issues I wanted to address, these are not exemplars, but they do happen a lot in our society. So again, I don't want you to graduate from nursing school without having heard some of these major foot disorders that happen and that people are high risk for. It's a mobility issue, and therefore it's fair game because it certainly can be a traumatic injury of mobility, and traumatic injury is one of the exemplars. So a bunion or a hallux valgus is a bunion on the interior side of the foot. Usually this comes from wearing really pointy-toed shoes or rapid foot growth, or it can be a congenital bunion. Some people have from birth the congenital predisposition to a bunion. You can see in the pictures on the bottom part of the screen how there's overgrowth of the bone right there where the toe meets the foot, the big toe meets the foot. Again, pointy toe shoes that always keep your toes pointed inward like this are more likely to cause a bunion. And what will the healthcare provider, the surgeon, podiatrist or surgeon will do is they'll cut over the skin, they'll shave off that bone overgrowth, they'll break the bones of the foot and realign the foot and then allow it 6 to 8 weeks of healing time, and they'll have straight feet with a shaved off bunion again. Best treatment is prevention. Hammer toe, another toe and foot disorder that comes from badly fitting footwear. Footwear that is too small for your foot, where your feet are crammed in, where it pushes on your big toe, causing your big toe to do this. I don't know if you can see that on the screen. There's also a picture of it down at the bottom of the slide. Cause the big toe to do this, and then it contractures in that position. Your other toes will overlie each other, and you'll have your big toe bend up or one of your other toes bend up from being crammed in those shoes. You also get corns at the joints that are bent up and calluses on the base of the toes that are the affected toes. Surgery also is the treatment here. So what the doctor will do is actually cut into these tissue, break the joints, disarticulate the joints, and put a pin in, and then allow it to heal over the course of weeks. All right, so here's just a play question. If the nurse assesses dry skin on the thumb and first 2 fingers of the hand of a 43-year-old computer programmer, the nurse might suspect the programmer suffers from carpal tunnel syndrome. See, that's an easy question. Look how good you're going to do on the test. So here's another couple of questions. This is on something from the last lecture, so let's see if you retained your knowledge. A 40-year-old patient flipped their car, comes into the emergency room with a leg deformity, edema in the lower leg and around the deformity, and a large, deep laceration over the side. He has a 25-pack-year smoking history. So going to bed is not good for this guy, right? He's really high risk for pneumonia, really high risk for gas exchange problems. He's going to surgery. So here this patient has an ORIF, an open reduction internal fixation, which means we did surgery. We cut into the tissue to reduce the fracture, pull it into alignment, and we fixated it with some kind of surgical intervention, a pin, a wire, a plate, of both the tibia and fibula, and then they're returned to the unit with a full leg fiberglass cast, full leg cast, and a window over the surgical site. Remember, the window is a little rectangular square cut into it so we can look at the tissues under it. Now, in this case, the window is cut in there because he had a deep laceration over the site. So he's going to require wound care and dressing changes and keeping that gauze dry inside the cast. So that's why the surgeon or the orthopedic surgeon cut a window in the cast so that we can continue to provide care to that site. So now this patient has a large leg cast. He's sticking around for a while because he's had this traumatic case. So at least we're probably putting him in here for 24-hour observation, because what care does this patient require? He has surgery to open up those bones. So he's going to be recovering from that reduction fixation surgery here in the hospital. So what care does he require? He has a cast. So we know he requires neurovascular checks every 4 hours. We are required to palpate the cast, look for hot spots. We're required to ask questions of the patient about their level of pain. Right away, we're probably going to have that cast elevated so that it reduces the edema. We're also going to be worried about his immobility. He's going to have pulmonary problems from his 25-pack-year smoking history and fresh surgery. So we're going to turn, cough, deep breathe, sit him up, and send him a spirometer as much as possible. We're going to try and get this patient mobilized as soon as we possibly can. If the provider will allow crutch walking, then that's great. If they won't, then probably up in a chair, up in a wheelchair, so they can at least move around, sit upright. We also know that we're going to make sure the cast doesn't have any sharp edges. He's a post-op patient, so the first day it's vital signs Q15, then Q30, and then Q hour times 4 times 4 times 4, and then to routine vital signs. So we're just going to be monitoring him and watching his I's and O's. He might need antibiotics because he's a fresh post-op, and usually orthopedic surgeries always get antibiotics pre and post-operatively to decrease the risk of osteomyelitis because it can be such a significant infection. So the third post-op day, you smell a foul odor, and he says he has terrible pain in his site. His vital signs reflect a blood pressure of 120/68. That's normal, right? But his pulse is tachycardic. His respiratory rate is right at the border between eupnea and tachypnea. His temperature is elevated. So what cues do we identify? Cues are the patient signs and symptoms that turn on our nursing clinical judgment. So we have a post-op patient, orthopedic injury, tachycardia, tachypnea, hyperthermia, and a malodor coming from a site that has an open wound under a cast. So what's your initial hypothesis? My initial hypothesis is that there's probably an infection going on. It could be at the laceration site, or it could be because it was an open skin injury. He now could have cellulitis or even osteomyelitis. We did surgery on his bones, used surgical instrumentation on his bones. So osteomyelitis is a very real possibility. So we're going to call the provider quickly because this patient can get septic very quickly from a systemic inflammatory process. And we'll get them started on antibiotics and fluids if he needs it. I'm not sure at this moment if he needs it because his blood pressure is stable. I would want a prior blood pressure as a point of comparison because if he always runs 160/90, and this particular instance now is 120/68, he could be suffering from hypotension even though his blood pressure is still within normal limits. So we want to look at we want a trail of blood pressure. So if I was on the NCLEX exam, I would go into the chart in the test question and look at the prior vital signs to compare these to what he was running just 2 or 4 hours ago. All right, so this patient, I'm sorry, I flipped too quickly. I'm going all over the board. This patient that I expect more frequent vital signs, calling the provider, getting an order for antibiotics, possibly a return to surgery for an incision and drainage of his bone. Not always, sometimes just antibiotics can cover it. But we want to use our good nursing judgment, our good processing care plans to decide what's wrong with this patient. So the next exemplar that we talk in these next few slides is amputation. Amputation is not always from a fracture or broken bone, but it can be a sequela of compartment syndrome. For whatever reason, we have compartment syndrome. This list gives you lots of reasons that somebody might have an amputation. Amputations can be traumatic or planned and surgical. So you can have a peripheral vascular disease where the patient has bad arterial perfusion to an extremity and it caused gangrenous extremities that require amputation. A patient with type 1 or type 2 diabetes has long-term vascular changes and neuropathic changes that can sometimes require amputation. That PVD, peripheral vascular disease, is a real big problem in a diabetic. On top with their atherosclerosis that's increased because of their diabetes, it narrows the arterial openings and they have decreased perfusion to their extremities. That decreased perfusion can cause necrosis of tissue, and dead tissue is prime for gangrene. If the patient actually has gangrene in extremity, it will require amputation of something. It might just be the tip of the toe we have to take off, but sometimes it can be more significant. We have to take off whole toes, half a foot, a whole foot. Just depends on how severe and significant the gangrene is for this patient. Traumatic injury can cause amputation. The trauma itself might have removed the limb, or they might have such damage from the traumatic injury that we have to surgically remove the limb. Battle injuries, intermittent roadside explosive devices that we're seeing in the Middle Eastern wars of late, in Vietnam, people stepping on landmines, they lost limbs, and so battle injuries can cause amputation. Thermal injuries like ice frostbite, where you are so cold, it shuts down the perfusion of the extremity. The body is just trying to protect heart, brain, and lungs. And so all the temperature is shifted to all the perfusion is shifted to your core to keep you alive. And you might sacrifice toes or fingers in a setting like that. So the hypothermic injury might end up causing an amputation. Cancer might cause an amputation. If you have a bad osteosarcoma, then that might lead the healthcare provider to remove the malignant tissue, which means the bone and everything distal to that. And then congenital disorders, that things that babies are born with, might cause us to have to remove toes, fingers, things like that. So what do we do? Well, we are assessing the patient's skin and perfusion. If we identify a problem, we're going to want to do some kind of diagnostic testing to help narrow down the cause. Of course, this is up to the physician to order. And I think you could probably identify. We're going to do x-rays. We're going to do Doppler flow studies, which are going to use sound waves to measure arterial and venous movement in the extremities. We're going to measure white counts, looking for infection. We can do arteriography to check how good the arterial perfusion to the extremity is. So there's lots of diagnostic tests we're going to be doing. There's a lot of things that we want, the terminology we use and general principles that we use for our patients. The biggest thing is we never take off more limb than we absolutely have to sustain life and well-being for the patient. So if we only have to take a toe or a tip of a toe, that's all we're going to take. We're going to take the least amount we can to rid the patient of the problem. So we always record the type of amputation based on where it's at. If we actually cut at the joint, we say we disarticulated the joint. But if we cut above or below a joint, we're going to name our amputation by the site. So we're going to have a below knee amputation, or above knee amputation, or above wrist amputation, or below elbow amputation, or above elbow amputation. So you'll see the patient comes up with a left BKA, a left below the knee amputation. So that's the terminology you need to understand. There's different kinds of amputations. If we get a closed amputation with a flap over it, then we're more quickly able to get the patient fit into a prosthesis. There are some surgeons that place prostheses almost immediately. Some surgeons prefer to delay prosthetic fitting until we've shrunk the limb and we've managed to control the edema. Guillotine applications are where we just do a flat cut. It's a straight open cut and the end of the leg or the arm is left open. Usually it's an emergent situation or a traumatic situation or after an infection. Most of the time, if it's a planned amputation where we knew the patient was going to have one, then we'll do an amputation that's a closed amputation that we're able to pull flap over right away so that the open end of the stump isn't just tissue, raw tissue. Perioperative care. It's really important for the patients to understand why this is important. Nobody wants to lose a limb. There's a lot of self-confidence, body image, and a lot of retraining your basic life functions once you've lost a part of a limb. So it's important that the patient understands and agrees with the procedure and is able to verbalize that to you. They need to understand what equipment we're going to use on them. Are they going to need crutches? Are they going to need transfer devices? They need to learn how to wrap their own extremity. So they need to know what kind of equipment they're going to need at home to manage their prosthesis. So we'll do that. We'll also start muscle strengthening exercises because if they're have to mobilize themselves with crutches or a wheelchair for a while or forever, they're going to need a lot more upper body strength. They're going to need more abdominal strength to help them transfer from place to place. So we're going to get them conditioned, get physical therapy to start working with them to be conditioned for this for after the amputation occurs. We're going to have the provider, the orthopedic surgeon, and the patient are going to discuss lifestyle choices, activities, and they'll determine which type of prostheses this patient might need. And then the patient will actually get instructed on the care of the limb afterwards before surgery. We know that before surgery, there's a state of anxiety, and that can help with teaching and learning. After surgery, the anesthesia and the pain can hinder learning. So we want to start the learning before surgery and then reiterate it and continue it and repeat it after the surgery. So hopefully the whole process, by the time they've heard it, seen it, and done it several times, will stay with them. They won't forget what they've learned. So post-operatively, now we have a routine post-op patient. So our routine vital signs: turn, cough, deep breathe, incentive spirometer, making sure bowel and bladder elimination is back, making sure that they are oriented to reality, they understand what happened to them. We're protecting the remaining limbs from thromboembolism, so they might have surgical compression hose on remaining limbs, TED hose on a remaining limb. The limb that has been amputated, most likely the patient will come back from surgery with soft dressings over it. So it's going to have gauze and pads and an ACE wrap. And the pads and gauze are generally meant to soak up any blood that might come. The ACE wrap is going to provide mild compression. That helps prepare the stump. It actually helps decrease the edema and prepare the stump. There's a picture at the top of this page showing you how to wrap with an ACE wrap and above the knee amputation. Some amputations are harder to wrap than others. This particular type of amputation requires a long, very cumbersome process to get that ACE wrap wrapped around the waist and all the way around the thigh, working it from distal to proximal up the thigh as we wrap it. This type of dressing is called a figure 8 dressing, where you go back, well, let's see. Yeah, this is a figure 8. So we bring it around and come back and cross back over it. So you have those nice overlapping lines up the leg. Okay, so post-operatively, we're doing our routine care for all post-op patients. We're going to manage their pain. Do they need opioids or do they need NSAIDs? What type of pain management do they need? Their dressing, post-op dressing, is going to be a sterile dressing change. Once closures occurred, it doesn't need to be sterile. So sometimes it's only a sterile change for 24 to 48 hours. And after that, you can do a clean touch. The stump will be elevated on a pillow most of the time for the first 24 to 48 hours to decrease edema. But at least every hour, you want to get that limb off the pillow, do a little range of motion on the hip, and then re-elevate it, because it's really important to avoid contractures at that hip flexor, because if the patient gets a contracture while their foot is elevated on a pillow and we never get good range of motion of their hip, then they might have a contracture where their leg bend up with that, and the use of a prosthesis becomes impossible because their leg is stuck out. We have to go in and break their hip in order to get them to use a prosthesis, and that is not a good outcome. And so lazy, bad nursing care is one of the reasons things like that happen. So stay on your toes, nurses. Be sure that you do good range of motion to that hip and that you elevate the foot, but then go back in regularly to do range of motion and position changes, and then go back to elevation. So if the patient has a leg amputation, it's also important after the first 48 hours to lay them on the abdomen a couple times a day, because that makes sure the hip flexor muscles are straightened out flat, and they don't, like if you're sitting up in bed, you're still contracting your hip. So you want to make sure they periodically get on their belly so that hip flexor can straighten out. Pain is a problem. There's real surgical pain from actually cutting into the tissues. That's very real and very immediate post-op pain. There's also phantom limb pain. Patients will tell you that their foot or their leg still hurts, even though it's been removed. So they'll hit their call bell and say, hey, my left leg really hurts, and there is no left leg. A callous nurse would say, oh, your left leg's taken off, it can't hurt, which is true and untrue simultaneously. Their left leg has been removed, but it does still hurt. The nerves that are traveling from the foot to the head that bring pain receptors have been cut. And they do not know that what's below it is gone. All they know is that that nerve has been traumatized and injured, and so it's still sending pain messages. For most of our patients, phantom limb pain will go away with time or decrease with time. For some patients, it's chronic, ongoing, lifelong. Phantom limb pain is described as shooting pain or burning pain or crushing pain. There's a couple things we can do to have your patient battle it. One of the things is making your mind and your cognitive awareness connect. So have the patient look in a mirror and see their body missing the limb. Have that become their new norm. And for some reason that process actually decreases phantom limb pain. It is real pain, and we treat it with real pain meds though, because it is a real nerve sending a message. The patient's going to have a compression bandage on right after surgery. Again, that will improve healing, shrink the stump down to its permanent size for prosthetic fitting. They also have residual stump dressings that can be used after the first day or two when the hemorrhage is no longer a big risk. That'll decrease edema. You're supposed to wear a compression bandage or a stump compression bandage 24 hours a day, not when you're bathing and not when you're doing, so maybe 23 hours a day. Not when you're bathing, not when you're doing your physical therapy, but every other time they're going to have that stump dressing or ACE wrap on. With a patient's post-op, we want to turn them gently, because if we move them quickly, it can provoke muscle spasms in that residual limb. You don't ever want to dangle the residual limb off the bed and just let it hang. You always want to support it. All right, and then we're going to look at the stump. The stump is the post-op surgical site. So we're looking at it for redness, swelling, irritation, skin breakdown. All those things would have to be reported. The surgeon's going to want to know if there's healing problems on their fresh surgical site. We're going to look at the color, the temperature. We're going to check the pulses, the closest pulses to the extremity that's been amputated. So your PowerPoint that's posted for you says the most proximal pulse on the stump. This says distal pulse. What I mean is the pulse site closest to your amputation. So if I do an above the knee amputation, the closest pulse site, it's most proximal for the patient, I guess, but most distal from your central body to the amputation site would be the femoral. Like if I take off above the knee, my femoral pulse site is the next best place to take a pulse. If I do a below the knee amputation, my popliteal site would be where I'd want to check pulses. If I do a toe amputation, I'm going to check dorsalis pedis pulses. because we want to make sure perfusion to the residual limb is good, and you want to document that carefully. You also want to assess the color, the temperature, and you want to compare the residual limb to the other limb to make sure perfusion is the same to both sides. You're not going to use lotion on that immediate post-op dressing. Lotions keep things moist. They can retain bacteria around the site. Until they've got good wound closure, we're probably not going to be putting any lotions and ointments on it unless the provider orders some kind of antibiotic or anti-infective. When we're wrapping the stump, every time it gets rewrapped after their bath or their therapy, we're going to elevate the stump for a few minutes, and then we'll go in and wrap it from distal to proximal, and that's to decrease edema and prevent venous stasis, prevent blood pooling in that extremity. By having it dangling and lots of venous blood in there, then wrapping it up, that blood can't get back. So elevate it for a few minutes and then wrap. The same thing's true if you're wearing support hose before you go to a clinical day. You lay down and elevate your feet before you put your support hose on so you don't trap venous blood in your feet before you apply the device that helps with venous return. Excuse me. Depending on if the patient's going to have an immediate or delayed prosthesis, the healthcare provider might have slightly different care for this patient. So you want to make sure you verified what you're supposed to do with your provider, and that the physician, you, the patient, and the patient's significant others or extended family are all on the same page and everybody knows what's going on. We're going to do good range of motion and muscle strengthening exercises of everything, arms, legs, upper body. Physical therapy is going to be working on that strength training. One of the things they recommend is every day, several times a day, have them push their residual limb, their stump, into a soft pillow, then get it a firmer pillow, and then a firmer pillow until eventually you can push the limb into a book or into a wall or into something firm. That is supposed to help with a couple of things. It helps prepare the stump for a prosthesis, the sense of a hard prosthesis against it, and it helps to control phantom limb pain for most patients. Make sure your post-op patient has a lot of protein, zinc, vitamin C, vitamin E. They need good wound healing, essential fatty acids. We have to heal the cells, and we have to build new cell walls, and we have to build new skin and subcutaneous tissues to heal that stump. Patients can have some body image changes. They're going to have some lifestyle changes. Skiing with a prosthesis is a little bit different than skiing with both of your own by birth intact limbs. So same with water skiing, swimming, walking, everything. So they've got to relearn how to do their hobbies, and they have to get a lot of emotional support through this process and learn to accept the new body image. Because they've lost a piece of self, Kubler-Ross's stages of grief and loss are very pertinent here. As the patient goes through the process of learning they have to have an amputation, having the amputation and recovering from it, you're going to see them going through anger, denial, bargaining, acceptance, depression. You're going to see those stages. Those stages don't always go in order. I didn't even name them in order, but they don't always go in order. And you never know when they're going to rear their head again, and they can come back for a year or two after the injury. So you can expect that grief will continue. We actually have a whole module on grief, whole module on grief coming up before test 4. So prosthesis care, the patient should always have a stockinette, one of those knit tube sock things, over their residual limb between their skin and the prosthesis. There's actually prosthetic stockings they can, like little stump stockings, or a stockinette that they can use. You're going to want them to learn, you're going to check, and then once they're on their own doing their own care, they need to check their stump for friction, redness, rubbing, skin breakdown every day. And we need to check their prosthesis to make sure that any straps, buckles, any kind of connective devices aren't fraying, that they're intact, that everything's working. We want them to clean their stump with mild soap and water, like ivory soap and tepid warm water every day. And again, check all the metal and leather pieces on their prosthesis for wear and secure attachments to make sure nothing is going to fall apart on them when they get up and put their weight on it. So again, these are the stages of loss we talked about: denial, anger, bargaining, depression, and acceptance. They're going to go through all of those. So we're going to do good nursing care. Don't argue them when they're in denial. Just let them process through and talk about it. If they're angry, remember they're not angry at you. They're angry at the situation. They're dealing with a loss. So we let them verbalize and let them process. The bargaining, we don't want to correct their thinking. You know, this is their personal grieving process. So don't go, oh, you're just bargaining. You're having grief from losing your limb. Don't worry about it. That is an uncaring response. You always want to reflect back, let them talk about it, let them process through it until they get to the stage of acceptance. All right, so 47, this is going to back up a little bit just because, oh, maybe not, let's see. 74-year-old female with insulin-dependent diabetes mellitus. So we've got a type 1 insulin-dependent diabetic that's admitted with an arterial embolism to the left leg. Remember, diabetics have increased atherosclerosis. Atherosclerotic plaques are irregular surfaces that are more prone for the development of emboli because it's an irregular endothelial lining of your arteries. So she's got an arterial embolism, which has blocked perfusion to their leg. Oh, look, I've changed genders. A 74-year-old female, he has severe pain. Sorry about that. The patient has severe pain in the leg and in the foot. And the patient orders TPA, tissue plasminogen activase. This is an enzyme-based drug that's designed to dissolve clots. We use it for pulmonary embolisms, for myocardial infarctions. We can use them in stroke sometimes. And here, arterial embolization. We can give TPA, tissue plasminogen activase, TPA. But this drug is going to dissolve all the clots in their body and prevent them from clotting for 48 to 72 hours. So any invasive treatments are kind of risky there for the next 24 to 48 hours. So the doctor ordered TPA when the patient came in, but no improvement was seen in perfusion. That clot had been there long enough, it actually had shut down perfusion to the leg. They tried hyperbaric therapy. Hyperbaric therapy is when we put them in a chamber and flood their body with 100% oxygen. It is under high pressure, so it transfers through the skin. Hyperbaric oxygen treatments are in most wound care clinics. They're used commonly to heal bed sores, pressure sores, any kind of wound that has ischemia as a root of the cause. Because flushing with 100% of oxygen that's actually pushed through the skin into your tissues can be a method of improving healing with that. So they did hyperbaric therapy 20 minutes a day, 3 times a day for a week. No improvement. The leg turned necrotic, and the decision was made to do an above-the-knee amputation. After surgery, what position do you place the patient in postoperatively? You're going to put them in bed with the leg elevated on a pillow, but with doing range of motion and moving that hip joint every hour. So you can have it elevated most of the time, but going in to do range of motion and change positions a little bit every hour. You can turn them side to side and still keep that leg elevated. You wouldn't want to go to the operative side because you couldn't elevate that. But if you can go to the non-operative side, to the back, to sitting up more, shifting weights, you can continue to reposition them, but keep that leg up and do range of motion on that hip joint. So that's your positioning. To facilitate healing of the residual limb, we're going to put a soft compression bandage on initially and leave it on most of the day. They'll have limb socks. We'll be pushing the limb into soft pillows initially. We're going to inspect the skin regularly, keep it clean. We're going to make sure that it doesn't get infection. So we're going to do just all our good nursing care. And then pain management concerns, I expect fresh post-op pain and I expect residual limb pain. So I might be treating both kinds of pain, and I'll be doing things to treat both kinds of pain. For residual limb pain and for post-op pain, distraction can help, right? Guided imagery can help. Narcotics can help. So can NSAIDs, like, drugs that cause anti-inflammation, and pain analgesia and anti-inflammation. So any of those kind of medications, depending on what's ordered for your provider. It's a post-op patient, we're still going to deal with his nutrition. If he's nauseated post-op, we're going to give him something for that. But for the we're going to get that good nutritional wound meal going. High protein, vitamin C, vitamin E, zinc, all the healing properties that we need. That ends our amputation discussion. There is great reading in your Lewis and your maternal child health book on this for the peds piece. So I'll leave you here and we'll come back with another lecture shortly. See you later.